So we now think about obesity as a brain disease. Nobody in the world is smart enough to cure it. We can now control it because we understand it.
People that would be prescribed these medications, they are on them for life, is that right?
It's very difficult for patients often to understand that they have a disease. The minute people stop the medication,
Up until very recently, there was the eat less, move more idea of weight management. And there was a lot of stigma associated with being overweight.
the minute you go on a diet, you are thinking about food all the time. And actually now we know that going on a very strict diet is a really bad thing for your body. And that's why
So welcome back to the Lower Dowling Experience podcast, where we are diving deep into the topic of weight loss and obesity. I have with me Professor Carel Le Roux, and he is an expert in the science of weight management, obesity, and the complex interplay between our minds, our bodies, and the environment. With a career dedicated to understanding how behaviour, emotions, and biology influence health, Carel's work has transformed how we approach some of the most pressing public health challenges of our time. We are going to explore his groundbreaking research and the real-life implications for individuals and families that we can all learn about creating sustainable and meaningful changes in our lives. So whether you're a health professional or someone looking to better understand your own habits or the habits of someone who you live with, or just curious about obesity, about weight management, about the psychology of both, then this episode is for you. And actually, Carel is also an athlete, but we'll talk about that later, will we? Welcome to the podcast.
well, thank you so much.
And thank you so much for joining me. And this is a topic that is very close to my heart. It's something that affects an awful lot of people, and it is still hugely stigmatised in this country and around the world as well. So shall we just dive into it?
Please do.
Yes. So obesity is your main speciality and metabolic health. And we're all hearing about this metabolic health and metabolic diseases now, where even when I came out of college, came out of pharmacy school, it was either diabetes and that was it. It wasn't really, we never really spoke about metabolic health. So can you just please explain to people what obesity is and how it affects the brain and how it affects the body?
So we now think about obesity as a brain disease, and it's the middle part of the brain that has this disease. So what this part of the brain will normally do is it will control how many fat cells your body wants to carry under the skin or also inside the organs. Now those fat cells are controlled, and therefore one person may carry a large amount of fat cells and another person a very small amount. That's biologically determined. It's not that one person is smart and the other one isn't. So therefore it allows us to understand obesity as a disease as any other disease. Now, if you have a disease in that middle part of the brain, then your body wants you to carry too many fat cells. Now, those fat cells cause the metabolic diseases that you refer to. So that can cause diabetes, or it can cause kidney trouble, or liver trouble, or heart trouble, or even diseases inside the brain, other diseases. So what I want to do is I want to make patients healthier. I don't really care how much they weigh, but I do know that if I can reduce those fat cells and the number of those fat cells and the size of the fat cells, then patients will ultimately become healthier. And that's the purpose.
Okay. And how do you go about doing that then with your patients?
So the most important thing to realize is that my purpose is not to treat the fat cells. What I want to do is I want to treat the middle part of the brain. So I want to treat that control mechanism. So imagine this. So we are sitting in your house. It's a really comfortable temperature right now. And you have a really good boiler system, right? You've got a good central heating system. You've got very good insulation on the windows. But the temperature inside the house is not controlled by the good central heating or the good insulation in the windows. The temperature in the house is controlled by a thermostat that you can control, and you decide if you want the house to be 21 Celsius or 22 Celsius. So think about obesity in the same way. It's not about energy in and energy out. What it's really about the control of the number and the size of the fat cells that you have. And that's what I want to fix. So that control mechanism is broken. in people that have the disease of obesity. But now we can fix that, and we can fix that with a nutritional therapy or a pharmacotherapy or a surgical therapy. All of that's valid, and I just now need to work out what is the right treatment for the patient in front of me.
Up until very recently, there was the eat less, move more idea of weight management. And there was a lot of stigma associated with being overweight. People thought that people that were overweight and obese were lazy, slovenly. Some would even think that they weren't as intelligent as people that were in a smaller body. So how did this change come about in even the medical profession's thinking of obesity? Because it's ingrained.
Yeah. And I think those are the two concepts. The first concept is weight loss. Okay. And the second completely different concept is the treatment of the disease of obesity. Now, if you want weight loss, what you will do is you will eat less and you'll exercise more. So eat less and move more. And that's a very good weight loss treatment. Unfortunately, what will happen is the number of fat cells and the size of them will reduce, but you will make the disease of obesity worse. And you will know that, and anybody that's ever been on a diet will know it, because the minute you go on a diet, you are thinking about food all the time. So that food noise comes back and is amplified, because that is what is supposed to happen. Your body is no longer in balance. And actually now we know that going on a very strict diet is a really bad thing for your body. And that's why your body pushes back so much. The opposite, however, is when we treat the disease of obesity, because then what patients come back, they say, since I've started this, I'm not thinking about food anymore. I'm eating the same food I've always eaten. I just eat less of it. And I think that is the main difference between weight loss and treatment of the disease of obesity. If we control the disease, the weight naturally follows. But if we just focus on calorie restriction, then what happens is the weight goes down and it bounces back, and you end up higher than you started. So if you want to gain weight, then the best thing for you to do is to go on a calorie restrictive diet, because you're almost guaranteed to weigh heavier 6 or 9 months after you've done the super diet than you did before you started. And that's what we do not want. The first rule in medicine is do no harm. And so what we do not want to harm patients by putting them on a calorie restrictive diet.
Okay. So we were speaking just before we came in here, and I actually had Mick Crotty, your colleague, on, and about 2.5 years ago, for about 2.5 hours actually. He was my longest podcast ever, but it was really good. It was a real introduction to everyone about obesity, because the weight loss, the obesity medications were just coming out then. And you see, I said weight loss medications and I had to switch to obesity medications, because that's actually... And we'll discuss that later, people wanting to go on them just to lose a couple of stone for a wedding, etc. But they were just coming out, and Mick was saying there was a 10%, body weight reduction when people use these. But now you're saying there's a 25% weight loss with some of these medicines too. So can we just discuss some of that new information that you have?
It's been a revolution, because in the last 2 to 3 years, now we actually are getting treatments that give a quarter weight loss. And this is similar to the weight loss that we see with bariatric surgery. And bariatric surgery is incredibly good treatment, and it's a very safe treatment. But we now see that with medications, we can get the same amount of weight loss because it works in the same way. And that's happened much, much faster than I could ever have hoped for. And now we are here. We do have treatments that give 20-25% weight loss. And now we have to work out how do we use them in the right way. And that's a really good problem to have, because, in the past, we didn't have these tools. But now we need to work out, how do we get this to get maximum health gain from patients? Not weight loss, but health gain.
Absolutely. So these medications, there has been issues with their supply. And there's been issues with black market supply of them as well. So do you have any intelligence about when we will actually have a consistent supply. Because even in the pharmacy, the HSE sent dictates out to us saying only for diabetic patients, etc., etc. And then you have people that are living with obesity going in with their prescription, feeling like as if they're being judged because they need the medication, even though they're not type 2. And you have the pharmacist saying, I can't give this to you. And it's an awful situation for everybody to be in. And people ringing around looking for pharmacies that do stock it. Do you have any clue as to when that might stop?
I mean, it has been a tragedy from that point. And, we, within the space have really shot ourselves in both feet. And that includes good-meaning people. Now, let me go back and say, these medications were made by some of the best companies in the world, and all the big companies now. Companies that make cancer medications for other chronic diseases, they are now all in this space because we now understand the science. And this is just biology. So it's not magic, it's biology, and therefore we can mimic it. But even these really smart companies, were out by a factor of 100, if not 1,000, when it comes to the supply of these drugs. They have these big marketing arms and they were thinking about how much are they going to sell. And when they launched, they thought it would be successful, but they were wrong by a factor of 100 or 1,000. So the supply problems that was created by them just not having enough medication on the market, that has actually shown the sort of quite a dirty underbelly of society. How can we say that one disease is more important than another disease? And again, the people in the HSE, that came out with this, they weren't bad people. But it just shows you that they don't consider obesity as a disease. They think somehow it's lesser than other diseases like type 2 diabetes, and both are important. So rather than us just saying, look, here's a big problem, we don't have enough, let's work out the patients that could benefit the most, right? And then you could make an argument even that people who have obesity and diabetes may benefit from these treatments, maybe more than people who have obesity that don't yet have the complications. People will understand that. Right? But what people don't understand and what is wrong is to say this disease is more important than that disease. And that's why we shot ourselves in the foot. So now we have to undo that damage. And, you had good pharmacists standing up in the middle of public saying to somebody, you can't get this medication because you don't have diabetes. And that has really broken down a lot of the very important, relationships between patients and their doctors, patients and their pharmacists. So we need to mend those bridges and fix it. And again, the way to fix it is just to understand that A, obesity is a disease, but secondly, obviously, to fix the supply problem. And I'm very pleased to say that we are very, very close to actually seeing those problems disappearing. And that's because these companies are good companies, they can manufacture things, and they have really put all their resources in. So I think the next year, 2025, we will see very few supply problems, But it also means it's because more companies have entered the market. So now you have more supply. That, of course, drives competition. And I also hope that will drive the prices down because there's so many people that could benefit from these treatments, but they can't afford it. And the HSE, remember, we live in one of the richest countries in Europe, and even our system can't afford these treatments for everybody. So we need to work out how can we be equitable. And equitable doesn't only mean to the patients or to me as a provider or you as a provider. It also means to society, the people who pay the taxes. So we need to have a grown-up conversation about this because it's not easy. But like any problem, we can solve it.
Yeah. But I think even the long-term effects of someone that is living with obesity, the fact that they could potentially, into type 2 diabetes, if we're looking long-term, the health benefits for someone to get these medications is so extraordinary.
We have these randomized controlled trials now. So one of the trials that we participated in, only published a few weeks ago, showed that if you take 100 patients with pre-diabetes, so that means your grandmother or your father had diabetes, you have a very, very high glucose, not yet in the diabetes range, but very close. If we take 100 people like them and we give them the best diet and exercise, and they lose weight with diet and exercise, 13 out of 100 will develop diabetes, despite our best efforts. Okay. Now, if you take the same patients, randomize them, that means that you draw their name out of a hat and some get the best diet and exercise and some get diet and exercise plus the medication. Now, you take 100 people at high risk of diabetes, you treat them with this, 99 will be disease-free. Only 1 out of that 100 will actually develop the disease of diabetes. This is incredible. Wow. So we can take somebody that's at very high risk who have maybe seen a family member suffer with diabetes and all the problem, and we can say to them, actually, not only are we going to stop you developing it, we're going to turn the clock back. We're going to make you normoglycemic. That means your blood sugar is going to go into the normal range. And that is very empowering to patients. And that means this is really what I would call health care. It's not sickness care. It's actually making patients healthier, preventing those complications like diabetes or sleep apnea, even heart disease or kidney disease. Those are the things we want to prevent. And we can now, and we have the randomized controlled trials to show that's possible.
Yeah, it's just wonderful. People that would be prescribed these medications, they are on them for life, is that right? Or can they go off them and maintain their weight loss?
So it's very difficult for patients to understand, because if you were told your entire life that, you are too heavy because you are doing something wrong, you are eating too much food, you're not exercising enough, you think it's your own fault. So we call it self-stigma. And therefore, it's very difficult for patients often to understand that they have a disease. And this disease is not their fault, but it is their responsibility and my responsibility to find a treatment for this disease. Now, if you don't think this is a disease, and I give you a treatment, and the treatment makes you feel less hungry, makes you feel more full, you eat less food, the weight comes down, you lose 2-3 stone on this medication, then what you do once you arrive where you want to be, you go, okay, thumbs up, I've got this sorted, I now know what to do. And they stop the medication. And the minute people stop the medication, the disease of obesity comes back. Now, the easiest way to understand this is, imagine you have high blood pressure, right? And I give you a really good treatment for high blood pressure, and your blood pressure comes down. Now, the minute I stop those medications, the blood pressure will be back up in 1 or 2 days to where you were before you started. So people generally understand that high blood pressure is a disease and we need to treat it like a disease. So all we're trying now is to say obesity isn't more special or less special than any of the other diseases. It's just another disease. So what I want to do, I'm not smart enough. Nobody in the world is smart enough to cure it. Okay? But we are good enough to control it. So if I can control it, then I can buy health. I can stop the heart attacks. I can stop the diabetes. I can improve the mobility so people can play with their children and their grandchildren, drive that quality of life, that functional quality of life. So again, coming back to this idea, it's just another disease. We can now control it because we understand it and we understand the biology of the disease. It's not magic. Whether or not I give these treatments or the man on the dark side of the moon gives these treatments, we get the same outcome because it's the treatment, it's the biology that makes the difference.
So can you tell us a little bit about how they work then?
Yeah, so all they do, they work in the middle part of the brain. That's an area that we call the subcortical areas of the brain, and it's the bit of the brain that controls how many fat cells your body wants to carry. So now, let's make up a number. Say you weigh 20 stone. Right? The minute I start the treatment, your body thinks that you are 4 stone too heavy. Right? And all that needs to happen is you need to go from 20 stone down to 16 stone. And while you are losing weight, you will feel less hungry, you'll feel more full, you'll be thinking about food less often, the food noise goes down, you'll eat smaller portions, but you'll eat the food that you enjoy.
Can I just stop you there 1 second? You say food noise.
Yes.
Can you explain what that is? Because I think that's really concise way of saying it, but maybe people may not get what you mean by that.
No, it's a really great term that patients have come up with. And it's this idea, when you wake up, you think, what am I going to have for breakfast and what am I going to have for lunch? And when you've had lunch, you just finish your lunch, you think, what am I going to have for dinner? And you have dinner and you have a good dinner and then you don't eat all of it, but you are thinking about food all the time. Right? And even if you're not conscious of it, in the subconscious, and sometimes people say, I'm just suppressing it the whole time, and then a really bad thing happens, at home or work, and I completely lose control, and I just eat an entire packet of crisps, right? And then suddenly when the food noise goes away, the same bad thing happens, and people go, oh, I'm not fussed, I'll do something else, right? So that is, to patients, one of the biggest releases. And that we call that the symptom of the disease of obesity. The Latin word for it is appetitive behavior. It's how hard will you work to get a reward, in this case, food. And once we actually treat the disease, people go, yeah, I'm not so bothered. Sometimes they even forget to eat. And also patients say it's like having 25% more brain space, because I can just think about all the other stuff and just get on with my life. I'm not thinking about food all the time. So that's the food noise.
Isn't it so interesting? Yeah. Okay, thank you. Sorry, I just had to, I wanted to qualify
absolutely.
that.
So when you're losing weight, this food noise goes away. But then when you go from 20 stone, now you get to your 16 stone where your body wants you to be. And now suddenly you become more hungry. You actually are less full. You eat more food. The food noise is actually coming back a little bit. But despite you eating more food, the weight stays at 16 stone. Right? And now that is really difficult for people to understand. And we say that what these treatments do is they disconnect what you eat from how much you weigh. Okay? Now, what I've just said to you, really, if I'm trying to explain to you that the earth is flat, it would be easier than explaining to you that what you eat doesn't really influence how much you weigh. But that's exactly what patients experience. But if I have told you, as the medical professional or the pharmacist have explained these medications or the nutritional therapies to you, and we said this works by making you feel less hungry, taking the food noise away, now you get to 16 stone, the food noise comes back, you're eating more, you think reasonably this medication isn't working anymore. And nobody is going to take a medication that doesn't work. And the mistake that is made then is the medication is stopped. And the minute you stop it, the body is under the impression that you are 4 stone too light. And now it forces you back up to 20 stone very rapidly. Okay? So that's what we are saying to patients is that don't start these medications if you are not prepared to take it for the rest of your life. Don't start a nutritional therapy if you're not prepared to take it for the rest of your life. Because if it works, we have to do this forever. Now, the treatments that we have now are very good, but the treatments that are coming in 2 or 3 years from now are much better, right? So in most patients' lifetime, we are going to be able to control this disease. I'm not sure that we'll be able to cure it, but we certainly will be able to control it. And that should give people enormous amount of comfort.
What would you say to people that say, oh, well, back when I was a kid or when in the 1950s or something, there was no obese people around. And if you go to a developing country, there's no obese people around. So it's all hogwash. This is a disease. People are just eating themselves into a state of obesity and, it's their own fault. I want to nip that in the bud right now.
So people who say that, are not bad people, that's an observation that is correct. Okay, there wasn't this much obesity, in the 1950s. But I will also say, in the 1950s, how many people had peanut allergy? Okay, peanut allergy was also not prevalent in the 1950s. But today, if I find you somebody, and there's a lot of people today that have peanut allergy, and I give them peanuts, I can measure their anaphylactic reaction. I can show you the biology of this disease. Right? And now it's true that the environment has changed, but stopping somebody eating peanuts doesn't take their peanut allergy away. And I think that is the way to think about obesity. There's no doubt that the environment has played an incredibly important role in driving this disease. We don't fully understand it. And, a lot of work is being done on this. But what we do know today is if I reverse the environment, so if I take somebody with the disease of obesity and I put them in a perfect environment where they only eat the healthiest foods, what will happen is they will lose about 1, 2, 3% of their body weight, but they won't lose 20% of their body weight. So reversing the environment doesn't reverse the disease of obesity. Reversing the environment doesn't reverse the disease of peanut allergy, right? Mm-hmm. But it also means that we need to do both. We need to treat the disease as a disease, but we also need to prevent it. Right? And therefore, we do need to have better nutrition, better diets, less processed foods. We also need to work on the environment so we can prevent people who are normal weight developing the disease of obesity. But for those people who have the disease of obesity, we need to treat them as we would do if somebody has high blood pressure or diabetes or asthma. Right? So we need to do both. It's not mutually exclusive of one another.
A lot of my listeners will be middle-aged women that are probably teetering on menopause, going through perimenopause, menopause, postmenopause, and they have a huge problem with what they call their menopausal belly. Now, we know that weight proportions itself differently on our bodies as we get older. And a lot of women have a hard time dealing with this because whether or not they were of a particular slim build their whole lives and they suddenly have this belly, or whether they always had a belly and now it's just that bit bigger. I've had women say, I've starved myself. I do 1,000 crunches a day and I still can't get rid of this. Can those women be helped with these medications, even though they may not fall into the obese category? Or what would you say to these ladies?
We understand that obesity is not depicted just by how much you weigh and how tall you are, so the so-called body mass index. Now, the medications are licensed for people with a body mass index over 27. So you take your weight in kilograms, you divide it by your height in meters squared, and that will tell you what your body mass index is. However, we understand there's a large number of people who carry belly fat especially, who develop other complications like diabetes or increased risk of heart disease, etc. So we are moving away from this idea that it's only about how much you weigh. We are now thinking, does this weight harm you? Okay. So if you carry some extra belly fat and, for example, your blood sugars start rising or your blood pressure starts rising, then what we would say is if we reduce that fat, then we can make you healthier. Now, it comes down to a mathematical term that we call numbers needed to treat. So how many people do I have to treat to prevent one heart attack? Now, if you are somebody that, is only a little bit overweight, but have had a heart attack, yesterday, and I start treating you now, I have to treat about 67 people to prevent another heart attack. And we think, the HSE thinks that's a really good number, meaning, that's worthwhile. We should invest in this, okay? But if you're somebody that's never had diabetes, but you have some belly fat, and now you are developing at a risk of diabetes, now I need to treat about 30 people to prevent you developing diabetes, right? But I may have to treat 100, 200 people, we don't know that exact number, to prevent a heart attack. Right? So that's where the risk level lies. So ultimately, we can reduce the amount of fat that's around the organs. And it's really that fat that sits around the liver and the pancreas, those organs that get the most detriment from the fat. And that's why it's worthwhile treating. Now, we would say all treatments are valid, nutritional therapies, pharmacotherapy. So if somebody tries a nutritional therapy, and we would always advise that as a good first step, and they are successful, job done. Right? So that's why we want more nutritional therapies in the system.
By nutritional therapy, you don't mean living in a calorie deficit forever.
No, I mean having a diet that makes you less hungry.
Okay.
Having a diet that makes you think about food less often. You enjoy the food, and actually it's enough. right? And so the quality of the food is really important. And that's why speaking with the dietitian is so valuable. However, if we try it, I can tell within 3 months if it works. If it works, we continue. If it doesn't work, I'm not going to make you go round and round in circles and beat you with sticks, and make you feel, bad about it. All I'm going to do is, okay, I'm going to say, fine, we have another choice. We can go to another nutritional therapy, or we can switch gears and go to medication. Thing is, all medications have side effects, right? And we always have to weigh up the benefits and the risks. But these medications are now so safe that, in the right, approaches, and especially if people understand the long-term way that we're going to treat them, these are some of the safest medications that we have at the moment. But we only need to use the medications if they don't cause side effects. And I think that's another important thing, why people need to speak to their pharmacist, why they need to speak to their doctor, because we can reduce those side effects.
Can you talk a little bit about the side effects, actually?
Yeah, so the side effects are very similar. We've just had Christmas, and we all know, after that third pudding, how you feel. Sometimes you feel a little bit nauseous and you think, I really should not have done that.
Yeah.
And you feel a bit uncomfortable. Now, that is because you've eaten so much food, it sends a signal to the brain to say, please stop. Okay. Now, what happens with these medications, and the same thing happens with bariatric surgery, that signal just happens much, much earlier. Okay. But it's the same feeling. Very often people can feel, whoa, I really need to stop now. Now, it can actually cause nausea, and I don't want anybody to have nausea. These medications doesn't work because of nausea. Nausea is a side effect. So now what we do is we start the medications very low and we increase very slowly, so that I don't want anybody to have nausea. But one of the other jobs of these natural hormones is they're supposed to make the bowel turn slower. And therefore, what we can sometimes see is people can develop constipation. Now, if that happens, you just need to speak to the pharmacist, speak to your doctor, because we can really easily sort that out. I don't want anybody to have constipation. We can give people extra water. We give them extra fiber. It's really easy to
little microlax if they need to. No problem at all.
No, absolutely.
Yeah.
But I just don't want people to have the side effects. And what we are seeing is that we were too aggressive in the past, especially in the clinical trials. Everybody wants to lose weight yesterday,
Yeah.
and people will put up with tremendous amount of side effects just for the hope of losing weight. Now what we see is you're going to lose exactly the same amount of weight if we go really quickly or we go really slowly.
Really?
Yeah.
Okay.
So because the weight loss takes a year to actually bottom out. Right?
Okay.
So if you lose weight very fast, you may lose, so if you're going to lose 4 stone, you may lose 2 stone in the first 3 months, right? And then the other 2 stone in the next 9 months. But then you may have nausea, etc. Now what we do is you say, it's fine. Let's lose a stone in the first 3 months. Let's lose another stone the next 3 months, and another stone the next 3 months, and another stone the last 3 months. So you end up exactly at the same place, but it's much more gentle.
Okay.
Right? I don't think people are prepared to take these side effects, but they're not going to take them for the rest of their lives. And that's why we want to be more gentle, get to the right dose. And not everybody has to go to the top dose, right? Because the top dose may be too much for them. So let's get to the dose. We call it the maximum tolerable dose. So, maximum is not optimum. So let's get to where we have the best control of the disease in you as a person. So gently does it.
Oh, it sounds so lovely. Like, that's holistic, isn't it? And it's the gently does it. I love that. Because people they just want, they want to lose it now. And you're putting your body through a lot as well when you're doing that. And so it's so important that you're very kind to yourself, isn't it?
Right. And that's also now why our dietitians love working in obesity clinics, because they no longer have to ask people to lose weight. The medication is taking care of that. But now we add the nutritional therapies and exercise therapies to make patients healthier while they're losing weight. Because when you lose weight, you don't only lose fat mass, you also lose some muscle mass. And what we're now trying to do is we want to reduce the amount of muscle that people lose. And the reason is so that you can be even more functional. So now our dietitians are working and trying to make sure you eat your proteins first, or make sure that you have the type of carbohydrates, what we call low glycemic index carbohydrates, effectively vegetables with a bright color, things that are red or yellow or orange or purple or green, because those foods give you energy and at the same time allow your muscles to be optimum while you're losing weight. So the focus is completely changed. So to healthy weight loss rather than maximum weight loss.
And I suppose there with the protein, etc., exercise is so very important for that muscle building as well, isn't it? Because people will be losing muscle and we don't want that to happen either, because obviously long-term of muscle loss is not ideal.
So you're right, and especially in older patients. Now, what's reassuring to us, and again, I come back to that, what I said earlier, is the first rule in medicine is do no harm. So we looked at patients who were much older and patients who actually had heart failure, where their hearts aren't pumping enough. So you may actually get that they become short of breath or they can't walk upstairs anymore. And when they were randomized and treated with these medications, what it showed is they lost exactly the same amount of weight than everybody else, but they became more functional. Suddenly, they could walk much faster. They could do more things. Now, it is true that they actually did lose a little bit of muscle mass, but despite a small amount of muscle mass that's reduced, they became more functional. They could do more things. And the reason is they lost percentage-wise more fat. So they could move easier. So we are reassured that we are not causing harm, but we can always do better.
Yeah.
And that's what we want to do now with better nutrition, with better exercise when people lose weight, so they can become even healthier than just the weight loss on its own.
Can I ask you, do people plateau then? So, for instance, someone may be a certain weight. So you picked 20 stone earlier, so let me say 20 stone. And they may get to 15 stone, but they're not 10 stone. And do they get upset then that they plateau and can't lose any more? And what does that mean? And how do they deal with that?
That is the biggest challenge that we have at the moment, because let's take that example. So somebody is 20 stone, they have an extraordinary result, they lose a quarter of their weight, and they come down to 15 stone. But they are bitterly unhappy with that. Right? Now, when we speak to them when they're 20 stone and we said, you may only get to 15 stone, they think, oh, that is amazing. I would give anything to do 15 stone. When they arrive at 15 stone, they go, oh, this is really disappointing. I would like to be 13 stone. Okay. But because this is biology, and it's important to say, it's not the smart people that listen to us that lose a lot of weight, or the people that don't listen, that don't lose weight. It is biology. Right? So say, for example, you now get to 15 stone and now you're on this plateau and you're pretty upset about this thing. And you think, okay, what am I going to do? I'm going to go on my super duper diet. Right? It turns out your super duper diet is going to work exactly the same as it worked before. You're going to go from 15 stone down to 14 stone. And then 6 months later, you'll be 15 and a half stone. That's why we don't want people to go on a calorie restriction diet once they've reached a plateau, because you actually undo some of the good things that we've done. Right? Now, if we treat people, and that's what the randomized control trials show us, patients, the Surmount 3-year extension study, people lost 22% of their weight, and for 3 years, absolutely flatlined. At 3 years, they still had 22% weight loss. Okay. So it means that the weight's not going to drift up, provided that you continue taking the medication and you don't do anything sort of crazy as in going onto a super duper calorie restrictive diet. Now, what do you do if you're 15 stone and you're bitterly unhappy about it? You have to think, what is the health gain? How am I going to be healthier when I'm 14 stone or 13 stone? And sometimes we can make an argument and there is some health gain. And then what we'll do is we'll use combination treatments. So very often we are now combining bariatric surgery with medication if needed. Right? And it is actually additive. So we can do that. But very often people will say, actually, it turns out that 15 stone, although I'm still heavy, I am a lot healthier. And I can't actually think how I'm going to be healthier at a lower weight. And interesting, what people also tell us is when they go from 20 stone to 15 stone, they themselves don't see anything different when they look in the mirror. Other people will comment and say, wow, you look great, you lost a lot of weight. But when they look in the mirror, they just see themselves. So
why?
It's because your body image and your body weight have very little to do with each other. If you think about people who have anorexia nervosa, they perceive themselves as grossly overweight, but actually their body weight is very low. So we want to manage expectations. And, sometimes I don't think it's harsh. I think it's clear. But I would say to patients, we as specialists in the field, we will not make you thin and we will not make you happy. Because people come to us in good faith because they want to be thin and happy. But what we need to be clear is that what we can do is we can make you healthier and more functional. And what you do with your health and functionality, that's your business. But we know that drives quality of life. So I'm constantly trying to shift expectations away from weight loss to health gain. And the health gains that's meaningful to a patient. Because only when it's meaningful am I prepared to take, a nutritional therapy for the rest of my life or a medication therapy for the rest of my life. So that's the thinking that's changed, when it comes to obesity as a disease.
That is very interesting because I think that people will always think, once I get to this weight, I'm going to be delighted with life and so very happy. And I've spoken to bariatric patients. I went to this big bariatric bash where I spoke to a load of ladies there. And the resounding thing that came out of it was, I thought I was just going to be really happy when I lost all this weight, but actually I'm not. I still have these demons in my head. I'm still the girl that everyone said was fat or lazy and I may have, some of them say they've switched their food addiction for shopping addiction, but so there's a whole psychology there that people will probably need counselling for as well. It's so nuanced, the entire disease, the entire spectrum of this, isn't it?
And when we can measure that, so in these randomized controlled trials, what we now do is we measure people's quality of life. And there's two domains. There's the so-called functional physical domain, and then there's the mental domain, of quality of life. And what we are seeing is that the functional domain gets better and stays better. But it turns out the mental domain actually only gets better a little bit while people are losing weight. But once they get to the plateau, they go back to where they were, to baseline. Okay. So what that means is we really do not make people happy with these treatments. But what we do is we take away the burden of the disease of obesity. And that allows people to engage in other treatments. Now, it may be seeing a counselor, it may be coming to terms with something. And that again is one of these ideas about health gain. So suddenly we just take this variable of obesity out of the way. And we say, look, this has not been the cause for some of the problems that you've had. So let's try and address that. And we are very fortunate in many obesity services that we do have psychology colleagues or psychiatry colleagues that work with us. Because in the old days, people actually thought this was a psychological disease. They thought it was like a lack of moral fiber and we just need to talk to people and tell them how to behave. Now we understand it's a neurological disease. It's not their fault, but we do have colleagues that can really help patients. Now, if our psychologists will tell you, they don't make people lose 1 ounce of weight, okay? But again, they make them healthier, right? They improve their mental health. And weight loss per se does not improve mental health, but it allows you to cope and deal with these things, as you should.
There have been some studies that have come out or some papers that I've read about the fact that people that may have loved alcohol, they drink less, or maybe even people that shop loads, they find they don't shop as much when they're on these medications. It's almost like it's affecting, dare I say, an addiction area in the brain that they may be addicted to or be dependent on. Have you seen or heard any of those things or not?
I read the same things and I thought, whoa, that's a bit of a reach. Right? And what we've just done is we've just completed an audit in one of the clinical practices with one of the general practitioners, Professor Carel, who've actually looked at his own patients. And he carefully documented when people came in Dublin, how much alcohol do they drink? He was quite interested in that. He didn't think anything of it. It was just part of what he did. And then when the patients came back at 3 months and 6 months, as his usual practice is, he asked about alcohol, and he suddenly saw this dramatic reduction. And it turns out it's actually the people who drink the most that have the biggest change in alcohol. Now, when you ask patients, they say, actually, when I have a glass of wine or I have a beer, I enjoy it. I drink it, I like the taste of it, I enjoy it. But I'm not drawn to it in the same way as I have. So I won't have a second or a third or a fourth glass, right? I will stop much earlier. And that's something that we didn't expect. So it just shows you how little do we really know about the brain. And it shows you how little do we know about the disease of obesity. And same thing is about binge eating now. A lot of patients are coming back to us and say, I had binge eating disorder before, and I was being treated for it. I found it very difficult. And now, since I've been on this treatment, I'm just not hungry. So I'm just not binging anymore. So suddenly it's gone away. Now, there's other people that have binge eating disorder that have significant amount of weight loss where the binge eating continues, right? So it just means it's two different diseases. And it allows us to actually become better at treating the other diseases. Because if you have binge eating and you are hungry all the time, I can tell you whatever the hell I want, it's not going to make you feel less hungry. But if I take the hunger away and the binge eating does not go away, then I have a much better chance of treating it with other approaches. So it just shows you how much we are learning. And it's really transformative for many people.
It absolutely is. I'd say we could have you back in a couple of years and there'll be even more studies or even, more revolutionary ideas that have come through from this. When I've spoken to a few bariatric patients as well, they've said actually they found that after they'd lost the weight as well, their relationship shifted with their partner, and sometimes not in a good way. The relationship broke down. They had got more confident. Their partner had become jealous. Lots of different things can happen. And you're saying that you can't make people happy or thin. And I think it's so important because I think sometimes what people think, and I know from all the questions that I've got in, is they think that if I get to a certain weight, my life will just be perfect. But there are other things that can happen as well that may not make it so perfect. Isn't that right?
You're correct, and it also shows you how society view people who have the disease of obesity. And very often society treat people as if they're not very smart and they're lazy, etc. And sometimes patients get really upset when they have lost the weight and suddenly now they get promoted at work. And suddenly now people are opening the door for them. And they say, but I've always been this person. I've always been this smart. I've always worked this hard. Why are you recognizing me only now? Okay. So it also shows that we as society, we need to change. And it's not just enough to talk about the stigma of obesity. We must change it. And we must understand it. And I would argue that one of the best ways to change the stigma of obesity is just to understand the biological basis of this. If you think about somebody that have the disease of epilepsy, if they sort of had an epileptic seizure and they fell to the ground and they started shaking 100 years ago, people would go to church and, light a candle for them because they were possessed by devils, right? Today, we understand epilepsy is a brain disease and we can treat it with a keto diet or we can treat it with medication or even sometimes surgery, of the brain. And yes, people with epilepsy, there's still stigma, but it's a lot less because we now as a society understand the biology of the disease. And I think obesity is similar. It's a neurological disease, a disease of the middle part of the brain, and all we have to do is understand it. Once you understand it, you can make up your own mind how you want to treat people. But I would argue that most people in society are good people, and they won't stigmatize people with obesity if they understand the biology.
Yeah, I absolutely agree. And you had said earlier about people opening the doors for people. You'd meant that women will find men start opening doors for them where they would have been invisible to them before.
Correct, and especially young people who maybe developed obesity when they were 10. And very often that's the narrative we hear from ladies, is they say, I've always been the biggest in the class. And, I almost didn't develop that skill set of dealing with attention, from somebody else. And now suddenly I've lost 25% of my weight. And now people are, interested in me, and I'm not used to it. And that also just shows you, what people have gone through.
God, it's so sad. I could cry hearing that, because we're all just people at the end of the day, isn't that right? And you wouldn't treat someone with cancer like that, or with, as you say, diabetes or epilepsy. So, and I think that having these conversations is so important, because people really do feel seen and heard.
Yeah.
When we have these conversations.
But to that point also, what we find when people now do come for treatment, very often they try and hide it. They don't tell even their own family that they're having these treatments because they're ashamed. They think that these treatments, be it a nutritional therapy or a pharmacotherapy, they think it's the easy way out. Right?
Oh my goodness. Absolutely. Yes, please discuss. I just had a message in there from someone saying, I'm going for bariatric surgery in the middle of January and I haven't told a soul because they'll think I've given up or I'm lazy. And
That's right.
I'm like, you're absolutely fantastic for doing it.
I agree. And it's when people have those treatments, and surgery is a great example, the medications, nutritional therapies, when they have these treatments and they are successful. I'm not suggesting you sing it from the rooftops, right? But at least allow yourself to view other people who have the disease of obesity in a different way. Because, we are all human, as you say, and very often people who have the disease themselves, they will be very judgmental about people who have obesity, other people. Right? And they actually say, actually now that I've had this treatment and I've been successful and I understand the biology, now I am treating people differently. And this is the idea. I don't want to, get on my little soapbox with my violin now, but it's this idea about giving forward, just allowing yourself to understand it and being kind to other people and understanding it's a disease. And it's a disease now that we can manage. No longer do people have to suffer. Now, let's be clear. I do not think people should be forced to have a nutritional therapy or a pharmacotherapy or a surgical therapy if they don't want to. But at least people now have the option. And we need to make sure that it's clear that these treatments are safe and they are effective, but that they are just normal biological treatments. And that's why we need to look after people's health in the same way as we would, for high blood pressure or high cholesterol. And that's why you need to ask your pharmacist, you need to ask your doctor about this, rather than asking a lay person that may be pushing a weight loss treatment on you. Think about this as something that's serious that you can manage, but you need to understand.
And where can people access this care? Is it as easy as walking into their own GP and getting it, or is it specialised clinics that they need to go to?
So I think general practitioners are the best placed in the world because GPs see patients holistically and they understand patients and their history over time. Now, it is fair to say not everybody are experts in obesity. And unfortunately, I work at University College Dublin and we don't have time. We don't teach our medical students enough about obesity. So even very, very, very good general practitioners may not have had any lectures at university about obesity. So they are also learning, right? But they are smart and they are getting it. So maybe your general practitioner will say, listen, I don't feel comfortable in doing this, but would you like me to refer you to somebody else that may help you? And ultimately, I work in an ivory tower, in a tertiary hospital. So my job is also to teach other doctors how to do this. And that's what we're trying to do. But there's always help. and there's specialist clinics, and there's specialist general practitioners like Mikroti that you mentioned before, that are really excellent and well placed to do this. There's hospitals, but also many general practitioners are comfortable, and also pharmacists now. Go and speak with your pharmacist, because they are in the community, they understand, they see, and they can also certainly direct people. So we always said in the old days, the public health message for obesity was eat less and move more. We want to change that message. Now the message should be seek help. Right? That's all you have to do. Ask for help, because there are people that can help you.
Can I ask you a little bit about, there's two little things that I wanted to ask you about. There's this term being bandied around now, it's called Ozempic face. Have you heard it? Where, the face gets a little bit haggard looking, I suppose, because of the weight loss. And then there's also the Ozempic babies.
Yes.
Which is just fabulous.
So the Ozempic babies is, a real positive. So there's a lot of people, who cannot fall pregnant because they have too much fat cells around the organ. So their body stops them falling pregnant. Now, the minute they start losing weight, they are able to fall pregnant. Now, of course, I get a heart attack if somebody is on the medication and falls pregnant. So we make it 100% clear, I do not want you to fall pregnant on the medication. And that's because we haven't tested the medication. Now, if it does happen, the sky will not fall and we immediately stop the medication, and that's what we do. However, it just shows you it's another health benefit. And you can just imagine somebody that weren't able to fall pregnant, and, if we can help people, it makes a big difference. Now, when it comes to losing fat, you do lose fat around the organs, and that's why the belly fat goes down. Okay? But you also lose fat under the skin. So people will see that their hip circumference comes down. Their waist circumference also comes down. But there's also some fat that sits in the face. And especially if the weight loss is too rapid or too much, what you can sometimes see is that people, will lose the fat in the face, and therefore, people call that Ozempic face if it's gone too far. And, that's why we also say you don't have to have the maximum dose and have as much weight loss as you possibly can. Sometimes people are what we call super responders. There's some people that lose half of their body weight on these medications. It's not because they are smart or they've done some wonderful thing. It's just their biology. But maybe that's not necessary. So the good news is first of all, when we start treating people, nobody is going to disappear. Right? Nobody is going to lose weight forever and disappear. But what we can now do is we can just reduce the dose. So we'll give you the dose that you require. And say, for example, you're a super responder and you may only need half the dose. Then that's what we will give people to allow them to stabilize. So there's nothing specific to the medication of one medication above another. It just has to do with the amount of weight loss. If you go on a super duper calorie restriction and you lose 4, 5, 6 stone, by a super diet, you're going to look exactly the same. But that may be too much for you. Yeah. So let's end up where we want to be rather than, the maximum.
Can I ask you a little bit about intuitive eating and what that means and how realistic it is for the masses, I suppose?
And we hear that quite a lot when people start the medication. So the first thing that happens is they say the food noise goes away. And the second thing that happens is they eat smaller portions. And then after that, they say, sometimes I forget to eat, And what we say to patients is that is okay. You need to eat when you are hungry, and you need to stop when you are full. And maybe on a Tuesday, you will eat 3 times a day. And on the Wednesday, you'll only feel hungry twice a day. That is okay. Do not eat if you're not hungry, because then you will start feeling nauseous. So that's what intuitive eating is. It's this idea that, let me ask you personally, how often did you drink water today?
I can't remember, but I do try. Maybe when I'm thirsty, I drink.
Yeah. So that's called intuitive drinking.
Okay.
Right? So you drink when you are thirsty. Now, I personally would like everybody to drink 2 liters of water a day, and I would like people to actually drink even when they're not thirsty. So that's a good idea, to be hydrated. But most of us, when and you don't drink at the same time of the day. You don't set your watch and say, okay, it's 10 o'clock, I must have a glass of water now. Most people don't. So that's the concept of intuitive eating. Now, we as humans, we are sociable. We like to eat in groups, you like to eat it with your family, etc. And that's great, So these treatments don't stop that from happening. You can still eat with the family, but sometimes people say, I don't eat off a dinner plate now, I eat off a side plate, and that's enough, right? And that's okay too, right? Don't feel bad that you can't, finish your plate. Dish a little bit less, and if you feel more hungry, have a little bit more. I don't want anybody to be starving. Okay? And that's the critical thing with these treatments. If you take these treatments and you are so nauseous that you are vomiting, then we have given you too high a dose. Then we have to reduce the dose and slow it down. So I don't want anybody to be starving. I want people to feel comfortable, to eat the food that they like. And most people know what good food is, and that's all they need to do.
Do people ever say to you after bariatric surgery or after being on these treatments, particularly bariatric surgery, because some of them just can't eat an awful lot at all in any one sitting, that they miss the social aspect of eating?
Yes, and that only happens in the first 3 to 6 months. And even with bariatric surgery, what we see after 6 months to 1 year, people go back to eat the same foods that they ate before, but they just eat less. And they actually eat a large amount they can eat a large amount of food, and they can perfectly, eat within society, and nobody else will notice. Okay. And the same thing happens with these medications. First 3 months, people really eat very little, because they don't feel hungry. And then, at 6 months, 9 months, they eat, very similar types of foods and also very decent portions. Now, that freaks patients out, right? Because they're like, oh my goodness, look how much I'm eating. I know the medication isn't working anymore. But if you ask them, what is your weight? They say, no, my weight's stable. Nothing wrong with my weight. But I know, I'm worried about gaining weight. So it's also about reassuring patients not to stop the treatment.
Yes, absolutely. So some people are non-responders when it comes to both the medication and even some bariatric surgery, or they'll lose the weight, but then they'll regain it. Is there hope for those people?
So about 20% of people, 2 in 10, who have these really good treatments, such as surgery or even these medications, don't lose much weight. Now, you can imagine how bad you must feel. You have the disease of obesity. You finally got the courage to have this treatment. Everybody else, having this amazing response, and you take the treatment, you do everything right, and you don't lose weight. And you go back to the doctor and, maybe the doctor says to you, oh, you must be a really bad person. Just look how well everybody else is doing with this operation or this medication. And just imagine the self-stigma that drives. So that's why we need to understand the biology. Coming back to it, it is not the smart people that lose a lot of weight and the people that don't listen, that don't lose weight. It is biology. And we say to people, if you go on to lose half of your body weight, it is not because you are morally superior. Okay. The flip side is true as well. If you are somebody and you don't lose any weight on these treatments, it's not because you're morally inferior. It's just biology. Now, the good news is we're getting lots of other treatments. And therefore, you may have a type of obesity that doesn't respond to this treatment or this operation. But you are likely to respond to another treatment. And that's the same for blood pressure or the same for diabetes. If you don't respond to one treatment, we change for another one. And that's how we're going to treat obesity. We're going to have lots of different options, and all of these options are valid. I want to reassure people that don't respond they have not done anything wrong. And also, I want to reassure them, it's not because it's bad medication or I'm a bad doctor. It's just biology, and we will be able to find a solution in the near term.
Okay, that's great. That gives people hope, I'm sure. Well, listen, I'm going to get you back in a couple of years' time now when there's been even more studies, etc. done. But I'll ask you my 2 final questions. The first one is, what advice would you give young people today?
Yeah.
Professor Le Roux.
So I would say if you feel that you are too heavy, okay, first of all, don't lose hope. We will be able to manage that. Secondly, change your focus away from weight to health gains. So I want you to have the best possible diet. I want you to exercise because it's going to make you healthier. So I would just like to give you hope because there's so many good things that's going to happen in the near future.
And what is the meaning of life?
So I think it's about, becoming healthier. Because if we're healthier, we're in a better position to look after others. And looking after your health is such an important thing because ultimately that is the best way for us to be in a position to care for those around us that really matter.
Oh, it's been an absolute pleasure having you on. Thank you so much for all the information you've given. Thank you.
Thank you.